and I'll start the discussion.
I already went to the first one, so I think
Oh
I'm
my
good.
gosh. Okay.
Great,
And
and
you
I
decided it's
changed
so
this.
good?
I changed this a little bit, Chris, to have something more upfront, but I'll try to run through it. And really, the work that the Integrated Care for Kids initiative, which has gone through now 3 years, has been around how we can transform the child healthcare system to be more preventive, developmental, and ecological. And really, I'm going to have 2 slides up front that kind of is a very brief summary of what we've found out and determined, and kind of the state of the field, and really does show that there is this imperative, if we're going to improve racial equity through healthcare investments, we simply have to have a focus, and really a predominant focus, on children and primary preventive and public health care services. So 95% of the work that we've been doing has been around what is practice transformation, how does that relate to metrics, and how does that relate to finance, and how does that relate to culture? And now we're really saying, we know enough to act, so how does that relate to policy? And specifically, how does it relate to the Build Back Better Act? And we had some help from McCabe Messaging Partners on what we were doing, and really around our message and the audience, and the ask around federal work. And the underlying message is to advance racial equity and to improve the population health. Health infrastructure investments must focus upon children and their healthy development, and give special attention to the places where they live, and responding to support the home and community environment. And that's the message. The audience that we're right now specifically focusing upon is federal policymakers, and we're trying to do so within their own vision for how they can build back better, and the $3.5 trillion bill that is working its way through Congress. Our ask at this point is not any major rewrite, but just specific tweaks to where the current Build Back Better healthcare investments are, to make sure that they get the greatest return, they're the most effective, and that is really by focusing on children and community health workers in the neighborhoods where the challenges are greatest. And we think we have a lot of child health experts and on-the-ground champions, including you folks, who can support this and get across this message. Both as a general, we want to provide this information in terms of community and policymaker education, and then to the extent that people can and have those avenues to do so through direct advocacy and lobbying. So these next 2 slides are just really condensation about why we need to focus on children and child health care in our responses, and particularly looking at the issue of racial equity, which is something that federal government and all of us are concerned about, and we know we're not going to achieve success in terms of population health unless we do something around the issues of equity. The first thing is simply, and it's Willie Sutton, you rob banks because that's where the money is. You invest in children in terms of racial equity because that's where the diversity is. It says that 24% of the senior population is of color, 50% of the child population is of color. So if we want to do something on racial equity, that's the population of greatest focus. When you look at what is government's specific and major role in financing healthcare delivery, it is in financing through Medicare and Medicaid. And here again, 25% of all people on Medicare are of color, and 65% of all kids on Medicaid are of color. And that's clearly because kids of color are much more likely to be poor and live in families which have their economic needs and not accessible to other forms of healthcare coverage. The third piece is that when we look at rebuilding our public health system and wanting to go to making sure that it's strong in all parts of communities, we know, and we use the Center for Disease Control and Prevention's Social Vulnerability Index, that if you look at those census tracts and neighborhoods with the highest vulnerability, according to the Center for Disease Control, that are most prone to poor health outcomes and most vulnerable to health epidemics, those neighborhoods constitute about 10% of the population, but that's where 39% of all kids of color live. It's actually where 3% of all white kids live. It really is the place where, if we're going to have better responses, we've got to make sure that our better responses are there. And that does lead into how we develop our community health network. And the final thing is, I'm a senior, and if you look at the senior population as a whole from 65 on, their years of life ahead are average 12 years of life ahead. Years of life ahead for the average child is 69. So we can work to try to improve health equity among seniors, but if we want those long-term lasting benefits and really shaping the future, we really have to look at kids. So that's just that we know why it's kids. The next slide says, we know what to do. We have evidence of effective practices, and this is where a tremendous amount of our work has gone, in providing primary care and in providing community-based health services. There are multiple evidence-based programs and practices that have added a community health worker, a partner in health, a door opener, a doula, a home visitor, but that person who's on the ground working with kids and their families from a holistic perspective. We have a tremendous knowledge base. These improve the safety, stability, and nurturing in the home environment and the child's healthy development. We also have multiple practice models within health systems like Reach Out and Read, Healthy Steps, Centering Parenting, Child First Adulthood, et cetera, that primary care practices can embed those workers above in a variety of different ways, or incorporate strategies for really connecting with families. And so we have that evidence base. The multiple health systems initiatives is too small to read because there are too many, and this is just a short list, but we have Bayview Child Health Center. We have primary care in Iowa. We have Montefiore Medical Center. We have some major initiatives to change the way the health system operates to really be family-centered, to provide family-centered health home, to adopt Bright Futures guidelines. And those have a tremendous research base. So we have these three different bodies of research looking at kind of specific programs or items. We also know that they share common attributes across these programs and practices as being responsive and culturally reciprocal, strength-based, relational and partnering in their work, inclusive and really equity-driven, community embedded in the places where families and their kids live, and with those frontline practitioners as essential agents of change. And I love to cite Partners in Health saying, we have these healthcare accompagneurs. They aren't a nice add-on to our professional practice. They are the core, and our professional practice can't work without them. They are the center of our organization. So in short, we know enough to act. Study after study after study confirms the value of doing this. And we now have, which we didn't probably have 20 years ago, a wealth of experts and people who've been doing this in the field that have the capacity to move forward, to train and support others, to develop the ways that it's done so that it becomes a new standard of care. And at a minimum, can get to that early majority of 40 to 50% of all pediatric practices to do something better. So that's our context. And now really going into, so where does the Build Back Better Act fit in? Where we are with respect to that and what we can do. And we're looking at Build Back Better because what we need at this point in time really is an investment in that infrastructure and those workers and those primary care practices who right now are not financed in any way to be able to reach the populations they serve. The House markup has 3.5 trillion over 10 years with about 900 billion directed actually to health infrastructure and healthcare. Obviously, there are negotiations underway on the size of the package, what's going to be in and out, and how long different programs are going to go. But we're pretty confident that the parts of the health infrastructure, significant parts of those health infrastructure will remain and will be a part of the final legislation. Much of the 3.5 trillion supports kids in ways that are going to improve their healthy development that aren't connected to the health system. The child tax credit, child care preschool, family leave, and some of the investments in education are foundational in improving healthy child development. And we certainly require concerted advocacy, and there's a lot of advocacy going on from groups on that, and that has visibility. What's true right now is that there's very little in that 900 billion in the bill that supports child and community health, although it could. It's sort of been in a lot of the statements and the visions of the White House and the administration, and there are bills in Congress and sign-on letters that really support investments here, but it did not get into the way the House markup was marked up. And that's what we're really hoping to change, and think it's still possible to, whether you call them tweaks or slipping in language, that would direct more focus to this. The federal audience, I really think that this is a time where there is this big recognition, racial reckoning, and commitment that we have to do something better, and we have to do something better by responding to underserved, marginalized, and adversely affected populations. One of President Biden's first acts when he came in was to establish an executive order saying that his administration is going to have that comprehensive approach to advancing equity for everybody across everything they do. It's reflected in what the Center for Disease Control and Rachel Walensky has said, that CDC has that critical role to address the impact of racism on public health, and saying racism is a public health issue, maybe the public health issue. The head of CMS saying that at CMS, how are we promoting health equity will always be the first question that we ask ourselves. So we have the intention, and I think it's more than nice political statements. It's really something that these leaders want to see done out there. And we're saying, great, but we want to make sure that kids are part of this. Where are the kids as you move forward in all this? And similarly, we have in Congress a lot of leadership that has made a commitment not only to the Biden agenda, but has been developing on its own different measures that would advance equity, and particularly equity through a much stronger community health workforce. And obviously, California is not waiting for the president and Congress to pass actions to do this. California has really moved forward with a community health worker focus, as well as other things in Medicaid and for child health. But there really is a lot there. It's, you know, in different offices, it hasn't necessarily all come together, but there's a public health infrastructure Saves Lives Act funding to expand the public health workforce, a health force resilience force and jobs to fight COVID Act, a building sustainable workforce for health communities Act, and a letter to congressional leaders from 141 members of Congress calling to create a public health system that really depletes the public, that creates boots on the ground workers recruited from and can serve their home community. So, during the campaign, Biden and Harris pledged for 150,000 additional community health workers, 6.5 billion in annual funding. And all those pieces above really are talking about that order of magnitude of investment. $5 billion at least a year for 100 or 150,000 new additional people who work in low and income and underserved neighborhoods. And so we're saying, great, you get it. Now, where are the Build Back Better dollars that would make sure that this workforce is financed? And there was some in the American Rescue Plan Act, but we're looking for it as far as an ongoing way in the Build Back Better Act. And here we find that their House markup, which they have done for their 3.5 trillion, includes around $900 billion in healthcare, in providing additional services for a whole variety of healthcare investments for about $100 billion a year annualized. That relates to expansions and improvements to the Affordable Care Act, the continuation of home and community-based services, enhanced support, making CHIP permanent, the expansion of Medicare for dental, vision, and hearing, and public health investments of $62 billion. So there is money in the Build Back Better Act directly directed to healthcare and health services. The challenge is that most of the provisions directed to Medicaid, Medicare, and the Affordable Care Act are primarily directed to adult health coverage and to chronic disease and disability management. It's not that we don't support those, but they are not getting at primary preventive developmental ecological supports to families and children to improve healthy development that we know work and are needed to address health equity. And the public health provisions are primarily directed to capital investments and to professional and medical care services. Again, not even really mentioning or referencing in the $62 billion in funding kids and families, except within the important, and glad to see it, $1 billion over 10 years for the 16-section momnibus or in maternal infant mortality recommendations. But that's 1 billion out of 62 billion. When we look further at this, we find that the public health infrastructure, you know, as I said, it is spelled out as 62 billion, and there's funding for core public health infrastructure of 7 billion, which should at least have a major emphasis upon community health workers. The funding for community hospital infrastructure, capital infrastructure for hospitals, the funding for community health center grants at least should include the ability not just to do capital grants, but also to add community health workers or child development specialists. And the funding in terms of pandemic preparedness, at least the funding for public health and preparedness research development activity, the 8 billion there, and the funding for other activities should include some help for community health services. This is a lot of funding, and there was just an article in the Minneapolis Tribune, which was done by a doctor saying, defund medical health, and really arguing, we're putting all our investments into medical care that has questionable impact. We should be putting it into healthcare and the supports of exactly this type. And we really see the opportunity and really the need to have in this 62 billion, at least a substantial share of it within these line items or differently constructed that is going to go and get to community health workers. So what we say is there are places that exist where you could emphasize primary preventive health care in Build Back Better, and you can focus on community health workers in marginalized communities. And therefore there needs to be a specific language that at least is permissive, but ideally carving out some of that funding, and that 50 billion of that current 900 billion at least should be directed to do so. And we have tweaks that can be added. We've written those up. We're going to the Hill and trying to get public attention to that enable some of that public health funding to go to the most underserved medically neighborhoods or direct it to, and really support community health workers. And when we go into those neighborhoods, you can't go into those neighborhoods and not have a major focus upon kids and their healthy development, because that's who lives there. And enable community health centers to do funding that would not only do capital projects, but also to add this capacity in their organizations. And the same in terms of Medicaid and the Center for Medicaid Innovation. There's the cartoon about the drunk looking for his lost car keys underneath a street lamp, and a policeman comes up and asks him, why are you looking under the street lamp? Is that where you lost them? He said, that's not where I'm lost them, but that's where I can see. Well, I think what's happened at the federal level is that the intentions at the policy level among the administration and White House leadership and congressional leadership is that they've said, yes, we want to focus on building back better in these ways that are going to address racial equity and population health. But a lot of who they've been contacted by, who've been brought in to develop legislation, who's been working, have been experts in medical treatment of disease, chronic healthcare management. And frankly, that means that a lot of what's happened has been guided by or informed by hospitals, nursing home, medical specialists, and MCOs. But if we want to look for where the keys to health equity are, it's not there. That's only going to produce a very small improvement in population health or other things. I think we can achieve some savings and some much better delivery of services there, but we're not going to achieve improvements in the long term in population health and reducing health disparities. It really is in primary and preventive and developmental child health and community-based health populations. It's that primary child health practitioner workforce and community health workers. As I said, we have a lot of data and information and research, and we have a lot of connections to others in the field around this. What is it in child health you can do in building a relational healthcare workforce? How will it dismantle racism? And how can it really be appropriately focused on geographies? And we also have messengers who can provide this message, who have agreed to be resources for us. Maxine Hayes, who many of you know was the chair of our group, and is a tremendous resource. But these are all docs. These are all pediatricians who have done this work, and many of them are now doing this work and showing why it works. And this is only a small portion, but I like to have people see this, because if we're going to be addressing issues of racial equity, and if we're going to be developing strategies that work, these are the folks who have the expert practice on the ground experience. And we have child equity experts as well who are in the field, and people on this call, I think, really are experts as well. But it really is a matter of our feeling of, we want, as the Build Back Better Act goes forward, attention to how do we use our goals of achieving racial equity and our willingness to invest new resources and substantial new resources to do so, to focus attention where it likely is going to have the greatest impact, which is around kids. So that's my kind of overview, and my want to stop now. And really ask you for your ideas and thoughts on, how can we get the ear of those in Congress who are drafting the legislation and in the White House and administration, and how do we make use of and get messengers that really policymakers want to lead and hear from in doing so. And I'm ready to do whatever I can to help and support. I had a card made up out of Have Laptop Will Travel, email Charlie, saying that I really feel like the action is out there and the knowledge is out there among experts and people like you in the field. And I'm happy to go and try to support your work, but I also Zoom, email, and tweet. So really like to now just open this up, and you've heard my presentation. I used to feel that I had an elevator speech, but I needed a building with 20,000 floors to give it. And I'm probably down to something of more Empire State Building floors. But I really wanted to get to you in terms of what your thoughts on this are, and how we might be able to move to the next steps in terms of